Perfect. All right, welcome everyone. We'll just give a few more seconds in case people want to arrive, and then I will get started with the intro. All right, so thank you all for joining us. Welcome to this rescheduled seminar. So it is now fifth in the academic year's GW Biomedical Cross-disciplinary series, the goal of which is to promote networking and collaboration in translational health among researchers, healthcare providers, and policymakers from different disciplines to shift the paradigm from seeking a cure to developing a strategy of prevention. This year, the GW Office of Integrative Medicine and Health has partnered with the Resiliency and Wellbeing Center and the Department of Medicine on the theme of preventative cardiology. To see the full lineup and recordings, visit our website, which we'll put in the chat, or you could just search for GW Biomedical Cross-disciplinary Seminar Series. Today, we'll hear from GW's own Kyle Levers on the role physical activity, exercise, and movement play in preventative cardiology. Dr. Levers is an assistant professor in the Department of Exercise and Nutrition Sciences and serves as the director of the Metabolism and Exercise Testing Research Services and Academic Laboratories on GW's main campus in Foggy Bottom. Dr. Levers joined the Milken Institute School of Public Health in fall 2018. Prior to his tenure at GW, Dr. Levers was an assistant professor of kinesiology at Longwood University, where he worked to significantly improve the strength and conditioning and sports nutrition curricula and facility, and to establish collaboration between the kinesiology program and the athletics department. Prior to his time at Longwood, Dr. Levers served as a researcher in the Exercise and Sports Nutrition Laboratory at Texas A&M University, collaborating with mentors Dr. Richard Creeder and the late Dr. Michael Greenwood on several large sports performance nutrition projects and women's health initiatives, while pursuing his doctorate in exercise physiology. During his doctoral tenure at Texas A&M, Dr. Levers volunteered his time as a strength and conditioning coach and research collaborator with Texas A&M Athletics, in addition to co-founding a startup wearable technology company to improve blood pressure monitoring accuracy during exercise. Dr. Levers' professional career prior to academia was grounded in athletic performance development at the Division I collegiate level and in the private sector. After obtaining his doctoral degree, Dr. Levers founded a strength and conditioning facility in New Jersey, where he served as the director of athletic performance and nutrition. Stemming from Dr. Levers' background in athletic performance development and collegiate athletic career, his research interests are broadly focused on the application of movement, exercise, and nutrition-based interventions as methods to enhance health and human performance. He's published several articles and co-authored 2 book chapters related to the influence of nutrition and supplementation on exercise performance and body composition. He also has presented at several regional, national, and international events on topics ranging from health and physical activity, weight management, sports nutrition, youth sports visualization, athletic development, and athletic performance evaluation. We are thrilled to have Dr. Levers with us today. With that, I'll turn over to you, Kyle. Thank you.
Thank you, Lee, so much. I really appreciate everybody's time and the opportunity to talk with everybody today. Excited to talk about this topic. I'm very passionate about physical activity, exercise, and movement. And when we're talking about human performance, I know my background, as Lee mentioned, is very much grounded into sport performance, strength conditioning, but I like to refer to human performance as just more of a general, do we perform as humans, right? And how well do we do that? And that's where today's presentation comes in. I also really think that this is a fantastic way to merge with the purpose of this seminar series, not with necessarily preventative cardiology, but beyond that and looking at prevention as a whole. And I'm not really sure that we do enough of that. So I think this is really something that is integral to how today's sort of health and medical communities can come together and work together to find solutions. So again, today we're going to be talking about physical activity, exercise, and movement. How do we prevent or improve the health of the cardiovascular system, the cardiac system in a preventative capacity? So what are we discussing today? Ultimately, we're setting the scene. I want to give you a general idea of sort of the human history of our physiological purpose, right? And where does the cardiac system, where does the cardiovascular system fit into that? Give everybody sort of the opportunity to be on the same page about what movement, physical activity, and exercise is. That way we can talk about what we do and don't have And what are some of the physical activity guidelines out there? Are they appropriate? What are the findings currently? Where are we going? And ultimately, what's the impact of our current sedentary, not necessarily us here in this room, but Americans in general, folks around the world, our current sedentary and inactive lifestyle? What is that? How does that impact cardiovascular health? And what happens when we actually refacilitate some activity and exercise, and what are the benefits? But most notably for today's presentation is, how the heck do we do this? We know so much. We have a lot of research out there in the physical activity, healthcare, health space. It says, what are the problems? We know what the problems are. We know what's going on. How do we work together, all of us in here from different aspects of linked professions and fields? How do we work together to facilitate solutions and effective solutions, things that actually work and that we see a measurable, detectable change on the population level? So that's what I want to address today. And sort of to set the scene, right? We are, as most folks understand, we're in sort of a dire situation with health and human performance. And so unfortunately, humans in general remain significantly inactive. And so this map here is again, something that came out of a 2017 to 2020 series of data looking at the inactivity by state, by region. This wouldn't surprise most people, I don't think, right? I was a little surprised about DC, but when you think about sort of the variability in DC and the access to different things that we're going to talk about today with respect to exercise and physical activity, it makes sense that we sort of fall into the yellow category. But just to give you a general idea, so you don't have to do any mathematical calculations here looking at the map, but you have 4 states and territories where we have the lowest 15 to 20% of the population are inactive, which is fairly positive in that way. But then we have 8 states where greater than 30% of the population are inactive. So, around a third of the population in those areas are considered inactive, which means that they don't meet the physical activity guidelines that we're going to talk about today. And then we have 41 states and territories that are somewhere in between. So not a good scenario here. And unfortunately, we know that poor cardiac performance, poor aerobic capacity or aerobic fitness is really the linchpin to a lot of other compromising disease states. So physical inactivity leading to improved cardiovascular function, leading to improved aerobic fitness is then something that we should be talking about for sure. So we really need to discover ways that we can ultimately work together and to find solutions and to improve so many different maps that lay out different criteria that look like this, that are problematic. I'm sure many of us have seen ones that are related to type 2 diabetes, obesity, basically all the risk factors that roll into cardiovascular disease. So what today I want to talk about, at least to start initially, on a local level, where do we stand? And it's just ironic that this presentation kind of came about because I've been thinking about this with some of my research collaborators and also some of our research assistants in terms of where we're at locally, something that a perspective, a sort of a surprising perspective, but I teach exercise physiology at the undergraduate level. We had lab-based experiences. We asked folks to do some things in our laboratory experiences to basically understand where their aerobic capacity is, among other things. And so what we're realizing is that basic measures such as resting heart rate, resting blood pressure, all the way up to maximal aerobic capacity, whether it's predicted or measured, is problematic in the current student population. And what we've been realizing is just something that seems incredibly low. My research assistants and graduate assistants were calculating some of these VO2 max parameters for these students, somewhere in the neighborhood of 25 to 30 ml per kgs per minute, which is incredibly low. That was further backed up by a fresh research study that Dr. Jen Sachek and I in our department are working on in terms of looking at freshmen and a whole host of physical activity, exercise parameters, both from a a survey-based scenario and also a actual physiological testing scenario. And what we were finding based on initial preliminary data of 2 years of doing this is that students feel like they have a moderate to high level of cardiorespiratory fitness. And when in reality, when we actually test it, they're extremely low, 25 ml per kgs per minute. To give you perspective, realistically, folks that are 18 to 20 years old should be well above 30 to 40 ml per kgs per minute. But we tested in our laboratory last summer, we tested a gentleman who is aerobically trained, but doesn't move very well. We tested him, did a VO2 max, obviously with approval from his cardiac specialist, but he tested his VO2 max at 34. So we have 18 to 20-year-olds that should be healthy and functioning with at least a moderate aerobic capacity. At least that's what they think they have. And they are far below somebody who's 84 years old. And so this is a significantly alarming scenario. And that's what I want to talk about today. Again, giving us a little bit of a local personal perspective. And so one of the things that I look at is, what is the human physiological system built to do? Well, it's really built and predicated on survival, right? That's the bottom line. So what are those things that were required as part of survival? Gathering, hunting, protecting, evading, reproducing, and obviously sleeping, right? That's it, bare bones. Get up the next day, repeat. And so that's what our physiological system is built and predicated upon. And unfortunately, as much as somebody that was consistently active at that point, obviously our modern day lifestyle has significantly changed. And so as a result, our expectations have changed, but also our physiology has not adapted to this new lifestyle in a positive way, right? So obviously right now, if you take a look at what we are designed to do versus what we're doing, we're running on outdated software, which is already something that we know. We have limited survival demands in our modern lifestyle. We have food, shelter, environment for the most part provided to us in some way, shape, or form. We're not going to gather it, hunting for it, et cetera, spending calories to do it. Sleep quantity and quality is very poor at this point on a population level. And a lot of our activity, our former activity and physical demands are outsourced. They're outsourced to other things, whether it's technology, other people. And again, it becomes a really, really dire situation when our physiological capacities do not meet or are not replicated by what we are exposed to. And so we are severely compromised, certainly from our outdoor exposure and circadian rhythm. That's a whole nother story. But really what we have done is, again, like I said, our physiological system is outdated software compared to what our modern day lifestyle is. And then I don't know if this population is really surprised why our cardiovascular system, among other systems, are performing poorly, but we shouldn't be surprised. We should not be surprised why our physiological system has not adapted to what's going on. So basically, to further talk about this, right, we've really engineered movement and activity opportunities and diversity out of our lives, right? And this is, again, just a picture to demonstrate that you have a young individual doing some physical activity by mowing, assumingly a lawn at his particular house, as opposed to most people who don't typically do that, who may outsource just one little teeny example, outsourcing landscaping, lawn care, things of that nature to other folks who are going to expend energy and also get maybe perhaps the cardiovascular benefit of those things. So what are we basically doing? We are outsourcing other technology to do the work for us, manufacturing, processing items. Basically, we're losing opportunities to express activity, movement, and of course, some type of fitness. And this has really become the societal norm, particularly as a result of COVID, which ultimately is a problem, right? And we've outsourced things as simple as carrying, walking, right, and food and water acquisition, which ultimately becomes a problem. So as I said before, why should there really be a surprise? that our cardiovascular system or cardiac system, things of that nature that are designed to be consistently physically or adapting the physical demands, when they're inactive, we shouldn't be surprised. And this is a good example, right? So if you have a car that's in pristine condition, my apologies, I'm a muscle car fan, but anyway, I have a car in my driveway that I take care of, I drive regularly, I use the systems all the time, as opposed to letting a car just sit for 10 years. What we would expect, we wouldn't necessarily expect the systems in that vehicle to operate like the ones that facilitate daily use. So again, I think the larger picture here is we know this. We know what's going on. We should not be surprised in terms of the impact of what is going on. It's not necessarily a mystery. In fact, we have a lot of research data to tell us exactly diagnostically what's going on as a result of physical inactivity and lack of exploration in that particular area. So one of the things that I want to do here before I get further into the talk is I want to, for everybody, to get everybody on the same page in this particular, this chat, or anybody that's watching this later, is what is the difference between movement, activity, and exercise? Because a lot of the physical activity guidelines talk about, obviously, activity, but exercise and movement aren't necessarily addressed. So when we're looking at this, right, the foundation of physical activity and exercise should be, and perhaps historically, just through the things I mentioned earlier, we're going to move well, we're going to move often, and we're going to move in multiple directions, planes, we're going to explore, we're going to do different things. And modern lifestyle has really complicated that scenario. So one of the things that we know is that these terms cannot be used interchangeably. And they're not necessarily used interchangeably in the literature, but in our common conversations with the American public or any general public folks, or even some professionals in the health and medical field, they are used interchangeably. And so I want to provide some clarity on that. So movement just really simply is active changing position, whether that's a joint or a whole body, right? And so for an example, it might be sitting to standing. That is a movement, not necessarily something that would qualify as a activity. And so I'm not sure that folks really engage in enough movement per day, or explore different movement opportunity options, which ultimately just means changing position. We're stuck on, I'm doing it right now, I'm standing at my standing desk, right? So what does that mean? That means changing position, going from a seated position to a standing position to a half kneeling position to a different position in my standing and sitting. All these things are critical to think about, to explore different actions, different motions, and obviously that's going to challenge the cardiovascular system differently. And so I don't think there's enough knowledge and education about that with respect to patients, clients, and things of that nature, just general everyday humans in our population. I don't really think there's even a prescription for this, right? So the nice thing is some of our wearable technology, for example, if you have an Apple Watch, you know what I'm talking about when you have to close your movement ring for a given hour, right? So at least as defined by Apple, right? They're saying that at least every hour you have to change position. Okay, that's a good start, right? Every hour of wake time, you're changing position. So movement really doesn't have a definitive quantity that we need to achieve, but it should be something that we do to refrain from staying static. And then if we sort of broaden that scope to physical activity, and this is something that the broad part of this talk is going to be focused on, but it's really any bodily movements that is generated by the contraction of skeletal muscle that facilitates caloric expenditure above our resting caloric expenditure, right? Anything above our resting metabolic rate. So more or less, what does that mean? All activities at any intensity above rest, right? That is not as small as changing position like movement is. We typically define it in METs, or metabolic equivalent of task, particularly if we don't have laboratory-based measures to understand that. Obviously, heart rate is also another way for us to define that, but it's typically characterized by mode, frequency, intensity, duration. And we're going to talk about that because the recommendations in some of the literature, as well as our general recommendations for physical activity, do describe things in that way. So one of the interesting things for prescriptions of physical activity. And just to preface this, just with some minor calculations, so we don't have to do any math today, but the time available in a given week, just to give everybody an idea, 168 hours, just over 10,000 minutes, right, a week of total available time. And you might say, well, that doesn't include sleep. Okay, I'll give that to you, right? Doesn't include sleep. So let's subtract out 8 hours a day. And I'm sure all of us wish we got 8 hours of sleep per day, but let's just say that we do, and we're healthy individuals from that particular aspect. So 112 hours is what we're left with, about 6,700 minutes of available time. Great. Okay. So we have that much available wait time. And I say that because as we start looking at things like the Healthy People 2030 physical activity guidelines from the CDC or the Department of Health and Human Services and their physical activity guidelines in 2018, what we're saying is that adults should be getting, if they want substantial cardiovascular benefits and substantial benefits regarding all the risk factors that are involved in cardiovascular health, need to get at least 150 minutes, and that's 2.5 hours a week of moderate physical activity. That's actually 2% of the available time, not 2% of the total weekly time, but awake time that we just calculate, 2%, or 75 minutes, which is basically 1.25 hours or 1% of vigorous physical activity per week. And one of the things that shocks me is that I play recreationally in a co-ed soccer league, and all my teammates and I, we got that, more than that, in one period, in one day last week. And we do that every week. So the bar is very low, but we need to understand why and when and what are the barriers to why people aren't able to achieve that as adults. And then if you want extensive benefits, right, the Healthy People 2030 defines as doubling all those parameters, the 300 minutes of moderate or 150 of vigorous per week. And then 2 days of muscle strengthening, very vague. And we're going to go into some more details about what the literature says about muscular strengthening. And then if you look at children 5 to 18 years old, 60 minutes a day, right? 60 minutes a day, 420 minutes a week, every day of the week. No definition really on intensity, but let's just get them moving every day. And they should be doing some type of muscular strengthening 3 days a week, which is also interesting. So those are the current guidelines, right? And we're going to go into whether we meet those or not. You probably surmise that we don't. But that's where we stand now. I do have a little bit, at least in my personal opinion, and again, this is not evidence-based, but in my personal opinion, it's interesting to think about that, as I said before, as humans, we're designed to be active. Our physiological system is designed to be active most hours of the day when we're not sleeping. Yet our recommendations sort of are from the bottom up. Our recommendations say we just have to meet the bare minimum. In my opinion, why aren't we thinking about how many hours of the day or how many minutes of the day or how many minutes of the week that we are not active causes problems, rather than how much activity do we have to achieve, right? We know that pretty much we should be active almost all the time, right? And again, our lifestyle has changed that, but that's how our physiological system sees every day, basically, is okay, we're ready for activity. And then when we don't do it, that's where we start seeing some individual problems. So now that we've defined some of that, defined some of the criteria that we're seeing in terms of how much physical activity, how much movement should we be doing, one of the things that I also wanted to talk about is exercise, right? So defining exercise as a subset of physical activity and something that is planned, right? So for planned goals, whether it's muscular strengthening, muscular endurance, aerobic endurance, right? So exercise has a plan, and we're setting time aside to go ahead and do that. It is certainly something that is a subset of physical activity. So just so everybody has a general idea. So how does this all tie in to cardiovascular or cardiac health, right? And cardiovascular function. And the reason I've sort of merged, I know the title of the talk is surrounding cardiac health, but in my mind as an exercise physiologist, I have a hard time differentiating the cardiovascular system from the cardiac tissue. And the reason for that is because of more of a systematic approach, which I want to talk about here in terms of health and in human function. So some terms that I want to kind of just lay out here regarding performance of this system, right? So ways that we, and I'm sure you in sort of the health and medical space, evaluate the cardiovascular system, the cardiac system's performance, right? So resting and exercise heart rate. One of the things I mentioned about our students is that their resting heart rates were getting into the 70 and 80 beats per minute range, and they don't know any better. And so we're educating them and saying that some of the folks that are more endurance trained or just trained in general are going to be somewhere around 45, 50, 55. And particularly for their age, for those resting heart rates to be that high and then to jump significantly high with the introduction of very, very low intensity exercise is a little bit alarming, and very alarming actually for a lot of us over here in exercise physiology. But resting and exercise heart rate, good way to monitor. Heart rate reserve, right? So what's our window of heart rate operation? Stroke volume, cardiac output, right? Obviously something that we can look at for performance. Blood pressure from a systematic standpoint, both at rest and during exercise. Rate pressure product in terms of heart workload. And then rate pressure product reserve. So basically, what does that look like over the course of the entire heart workload? What does the heart workload range look like as opposed to a single snapshot? So what is the general function for the heart and human performance and really survival? If we go back to the initial part of this conversation, is it's a fluid pump. It's designed to deliver blood to the arterial system and also itself as the myocardium, right, via changes in pressure and flow. And so really its function in the cardiopulmonary system is obviously deliver blood to the lungs to facilitate gas exchange, right? So that's critical. We see that in this picture here. And further, what we're looking at is the function of the heart and the cardiovascular system. So more specifically, we're looking at the blood as a vehicle of transport. And there's so many different things that are going to be transported within the blood, including ions, hormones, and metabolites, but most notably oxygen. And so when I went back and said earlier that aerobic fitness is absolutely critical and something that we're seeing sort of slide, as well as the quantity of physical activity, that's going to be something that's important and highly relevant to the function of the cardiovascular system. We also know that the heart and the cardiovascular system regulate body temperature and pH, which is critical. So all of these things in terms of performance, and you can see a little bit of a diagram here, very simplistic and crude, obviously, but all of these things are important for survival. Again, this system is operating on is outdated compared to our current lifestyle and modern lifestyle. So what is ultimately the limiting factor in our performance as a human, at least from a cardiovascular standpoint, is oxygen delivery to the tissues, right? We need to facilitate that, particularly for increasing performance as a human, whether we're doing activities or we're even at rest or during exercise, which is a little bit of a planned physical activity. We need oxygen delivery to and uptake of that oxygen into the exercising or working tissue. That's absolutely critical. Tends to be the limitation from an adaptive standpoint. So in order to deliver that oxygen, the reason that is important, obviously, is for aerobic respiration and oxidative metabolism of fuel sources, particularly fats, carbohydrates in active tissues. This is how things like metabolic disorders perhaps may be tied in. So as a risk factor, but also something that is implicated by cardiovascular system dysfunction, can be critical in terms of acknowledging that performance. So we know that a lot of these things are interrelated. We know that cardiovascular system, again, like I said before, is sort of the linchpin, and functionality of the cardiovascular system and activity is important. And one of the things that we can also talk about here from a cardiovascular disease standpoint or a coronary artery disease standpoint is how do we control that blood flow and oxygen supply to the active tissue and musculature? And so we know generally vasoconstriction, vasodilation, and that smooth muscle that is facilitating that control of the diameter, basically, of the lumen and the components of the arterial system via the autonomic nervous system, parasympathetic, sympathetic, vasoconstriction, vasodilation. That requires, all of that requires pliability of the arterial endothelium, which obviously is something that can be a major problem in more of a disease state. So we know initially that this is what is required to have some type of basal function in performance and survival, at least from a cardiovascular standpoint. We need to take care of those particular things. So what are we seeing in terms of ultimately, how do we define cardiovascular responses to activity and exercise if a healthy individual were to engage in that? And ultimately, what we see is heart rate's going to increase, stroke volume is going to increase, which facilitates increase in cardiac output. And so what we see from an acute standpoint is a lot of the parameters that you see here. So you see cardiac output and stroke volume. And one of the things for the different comparative lines that you see on these graphs or these figures is you see obesity, folks that are obese versus folks that are healthy, right? You can see sort of the differences, not the point of this conversation necessarily, but as a risk factor associated with cardiovascular disease, I felt it was important. But we see stroke volume increase with increasing exercise intensity, so does cardiac output and heart rate. So we know that physical activity and exercise is a challenge to the system, and that intensity has to come with that. We have to challenge the system with some type of overload to facilitate some type of adaptive response. And so this is an acute scenario. That's what we would expect. We also would expect, as you see in this listed in this figure, we'd also expect systolic blood pressure to increase as well in response to exercise demands. And so what we know is that aerobic and resistance exercise does facilitate these changes, but there are differences in the way that blood pressure is going to be regulated and also facilitated by these different types of exercise. So just be cognizant that there is going to be differences with certain populations. We are not necessarily going into secondary prevention or secondary response of folks that have been diagnosed with coronary artery disease or cardiovascular disease in some capacity, but just acknowledging that pressure, without going into too much detail, is going to be different between those different types of modalities, and that we should be cognizant of those, most notably the increases in pressure associated with different types of resistance training, as well as aerobic training. So the other thing that we know, obviously, we said rate pressure product of workload on the heart. So workload on the heart as a result of heart rate times systolic blood pressure, if they both increase as a result of increasing exercise intensity, the workload on the heart is going to increase as a result of doing exercise or physical activity of increasing demand above rest. And this is why exercise is critical, or physical activity is critical to all populations, no matter what modality that you're using. We need to challenge the system so it can adapt accordingly, because if we don't challenge the system and we remain sedentary, again, we shouldn't be surprised in terms of the disease states that occur as a result of that. So the general patterns of chronic adaptation that we see with the cardiovascular system and the cardiac system in response to aerobic and or resistance type activity or exercise in a healthy, normally functioning system is that we're going to see increased parasympathetic influence, and resting heart rate's going to drop, and we're going to have greater stroke volume or greater capacity. And you certainly see that here in some of the diagrams. But And we know that as a result of that, cardiac output is going to increase. And this is for different reasons, depending on the exercise stimulus or the physical activity stimulus that you use. If you load the system, it has to overcome greater external pressures in the system as a result of resistance exercise, then the heart is going to hypertrophy differently than what we see in more of a volume-based, from aerobic exercise, more of a volume-based adaptation scenario. And so one of the things that is interesting is that we see blood pressure, lower blood pressure as a chronic adaptation certainly occur cardiovascularly, greater tissue capillary density as a means to improve oxygen delivery through that challenge, and better oxygen extraction capacity in the periphery, as well as an adaptation to chronic exercise, particularly aerobic exercise. And then lastly, what we also see is a better efficiency to blood flow to active tissue, and also our better ability to cool and regulate temperature of the system. And again, physical inactivity and lack of exposure to changes in body temperature, core body temperature, as well as dealing with ambient temperature through activity and exercise in the outdoor environment, or at least in an indoor environment that's not regulated for us, is going to be a huge benefit in terms of a chronic adaptation. So one of the things that I wanted to discuss as well is looking at apologies, the slides are not progressing the way I wanted them to. There we go. Okay. All right. So in terms of physical inactivity on endothelial function, right, there's certainly some precursors that as a result of physical inactivity, one of the things that the endothelium, as I explained earlier, within the or surrounding the lumen of the vasculature, right, that ultimately when we have some things as a result of physical inactivity, and again, we see some comorbidities and things that roll into cardiovascular disease, or risk factors that roll into cardiovascular disease, we can see that a lot of these things very, very generally, again, not going into the mechanistic details here, but looking at how they play into an oxidative stress environment, which ultimately facilitates reduced nitric oxide availability, and nitric oxide being one of the primary tenets, the ways that we can control vasoconstriction, vasodilation, basically blood flow, and whether that be blood flow to the cardiac tissue or blood flow to the body, it's absolutely critical to understand a lot of these other mechanistic ideas when we don't use the system for the way that is intended. And then we have this arrival of disease states that occur as a result of disuse, just like the car sitting in the driveway for 10 years. If we don't challenge the system through increased blood flow, increased pressure in the system, increased cardiac output, things of that nature, there's no way that the system has to adapt. By the system, I mean basically the endothelium adapting to increased pressure, increased shear stress within the vasculature as a result of those increased volumes. And then when we have some type of incidence of injury to that endothelium or vascular wall, and the repair process is implicated and also chronically exacerbated due to systematic high blood pressure prior to exercise at just a resting level, we can certainly have an issue in the development, obviously, of endothelial dysfunction, but then also as a contributor to disease states that are related to cardiovascular disease and coronary artery disease. So as a result of that, okay, what can we do? Why is exercise beneficial in this capacity? So when we're looking at exercise being beneficial here, just from an endothelial function standpoint, is that if we challenge the system to increase endothelial function and reinvigorate the ability for the system to respond to nitric oxide, to produce nitric oxide, to influence the smooth muscle surrounding the vasculature, right, it's going to be incredibly important to overcome some of the inflammation, the systematic basal layer of inflammation that exists in those systems. So just sheer doing some increased activity and doing what the system is designed to do and reintroducing that is going to be beneficial, in addition to all of the other benefits regarding some of the factors that contribute to cardiovascular disease and coronary artery disease. Again, getting back to increasing activity will help the system better adapt to the exercise stimulus and help to alleviate some of the risk factors that exist in cardiac issues. So one of the things, just as a quick sort of overview of what's going on, the positives and negatives, the benefits of cardiovascular-based physical activity and or exercise, and how the cardiovascular system typically adapts, what happens when it's in a disease state, and what happens when we reintroduce physical activity. And all the research out there, the substantial part of the research out there is going to facilitate a good amount of adaptations and benefits within the system as a result of reintroduction of a exercise and physical activity, particularly in a previously sedentary or inactive population. So something I wanted to return to, and this is really the Healthy People 2030 recommendations, and these are objectives laid out by that committee, and I don't necessarily want to go through them one by one, but basically what we're saying here is different targets, right? So the current is where we were at the end of 2020 or 2020, the gap between 2010 and 2020. And so some of these goals here, obviously reduce the number of adults who do no physical activity, that are completely sedentary in their free time, right? So we want to reduce from 26 to 21, adults who don't get enough physical activity for substantial health benefits. All of these objectives we really didn't attain in 2010 to 2020. So we're setting new objectives or modifying the objectives from 2020 to 2030. The thing that bothers me a little bit, and I understand why we do it, the thing that bothers me a little bit is most of these are about a 5 to 6% change. And if we're going to get things done, we need to be more drastic in our approach, because it'll take us a century. If we go 5% every 10 years, it's going to take us a century to get some of these changes to occur. So I think we need, again, part of the reason why we're having this conversation is how the heck can we do this? How the heck can we facilitate some solutions here on more of the population level? How can we work as health and medical professionals to be able to do that? And so one of the things that we've tried to do is obviously reintroduce physical activity. We know that physical activity and reintroduction of physical activity within our lifestyle is going to facilitate reduction in cardiovascular related deaths. It's going to facilitate improvements in some of those risk factors that we were talking about before. And this is exactly what this figure is showing in terms of kcals per week and how much we have a reduction in certain events that you see here, as well as MET hours per week. So MET's referring to a metabolic equivalent of tasks. So basically how much above resting oxygen consumption somebody is doing. So the higher the METs, the higher the exercise intensity and the higher the oxygen consumption required there. So as a result of basically outsourcing and engineering movement and activity out of our lives and modern lifestyle, what we've tried to do is reintroduce it and basically tell people, give people ideas of what we can do. We've created whole industries in terms of fitness, recreation, corporate wellness to try to reintroduce things that we used to do just normally. So what are some viable solutions, I guess, is the bigger point, because again, like I said, I'm not happy with the 5% in a decade of increased people being physically active or reducing the number of people who are inactive. I think we can do better than that, and it's going to take some creativity. But ultimately, what the research is saying around this is that we know that we're going to get better cardiovascular benefits as a result of increasing physical activity. In fact, somewhere between 30 and 50% of risk reduction in cardiovascular mortality, 20 to 50% risk reduction in all-cause mortality. And there's so many figures out there that I could label and name throughout a lot of the research that exists. But that's just a group that had done that under the primary author Kadama et al., doing that in 2018, figuring out some of that information and data. But ultimately, there are a whole host of information to demonstrate the positive benefits of physical activity. And again, we shouldn't be surprised by that, because that's what the human system, the physiological system, is designed to do. It's designed to be active. So go figure, we increase activity and we see positive benefits in terms of the risk factors and events of cardiovascular disease and also all-cause mortality. So it really shouldn't be something that surprises us. But the thing that was a little bit interesting that I found evidence of more recently is a group under the primary author Van Hees et al. Basically, what they were looking at is the closer somebody is to an aerobic capacity, aerobic fitness of 0 ml per kgs per minute, the closer they are to mortality or all-cause mortality or death or cardiovascular events, right? So we said that our students average in our FRESH study is at 25, right? And just to give you perspective in terms of the range, we tested one of our endurance athletes here at GW earlier this week, and this particular individual's VO2 max or maximal aerobic capacity was 77. So you can see the range, 0 to 77, 0 to 80. Now, granted, that's the top end of the scale, really well-trained individual, but our 18 to 20-year-olds are very, very far off of having an acceptable aerobic capacity, aerobic fitness. So what we know is that if we increase aerobic fitness just by 1 MET, just by 3.5 ml per kgs per minute, we have a 13% lower risk in all-cause mortality and 15% lower risk in cardiovascular disease or coronary artery disease. So that's something that's really interesting. And it seems like aerobic fitness is actually a more pronounced indicator, at least by 2 studies discussed by Lee and Blair et al. All right, really telling us that, hey, aerobic capacity, more so than even physical activity level, is going to be a better indicator of cardiovascular morbidity and mortality. So I think we not necessarily looking at the wrong evidence, but something that we need to expand our evidence in a little bit of a wider scope. And so in the journal, the European Journal of Preventative Cardiology, one of the things that's really interesting is some figures that were put together by, again, Van Hees et al., and looking at, just give you perspective of what different exercise intensities and training zones. Again, this isn't really important to a lot of folks because we really just want to get them active and doing something, right? Moving, doing something. But in case you were interested, or your practitioners or folks that you're working with are interested in how this lies, how does it line up with METs and percent of VO2 max, percent of heart rate reserve, percent of heart rate max, somebody's rate of perceived exertion or RPE, where does moderate intensity, moderate effort line up? And I like this table because it kind of gives people perspective depending on what type of wearable you're using, what kind of tests have you done, right? How are you rating your intensity? Gives us a general idea, because what we've said earlier in the Healthy People 2030 guidelines alone, moderate physical activity, vigorous physical activity, what the heck does that mean, right? So again, providing some clarity to people, I think, is going to be incredibly helpful. Secondarily, what we also see is some better recommendations. I like these recommendations, not necessarily because they're different, but they give us some more detail. Now, maybe more detail for some folks is not necessary, but as folks who are programming for people who need greater activity, it gives us an idea of what different populations may need. And also it gives us an idea of some of the intensities that they need to be at. Most notably, resistance training. What's the frequency, duration, intensity that somebody needs to do in order to determine or facilitate cardiovascular changes in health? So this table, I think, is highly, highly valuable. Again, I'm not going to go through the details because I think it's a good reference for you all to come back to should you need it, but it gives you a very, very general idea beyond the guidelines that we discussed earlier. So with that said, what I want to talk about now is what kind of lifestyle solutions can we come up with? Because this is really what it boils down to. It's lifestyle solutions. As medical and healthcare professionals, what can we do to facilitate a more global impact on the population, right? Because again, like I said before, I don't think 5% in my mind, personally, anecdotally, is acceptable in 10 years. I think we can do a better job than that. And if we're going to make big changes, we need to really facilitate that in order to improve health of our population. So some of the big things in terms of ways that we can facilitate interventions for the adult side of things is where are the biggest touch points? So some of the things from a lifestyle and the modern lifestyle, what are some things, what are the areas? Most notably work. Work is an area where we can increase sort of activity and physical, really physical activity and exercise opportunities, whether it's exercise through corporate wellness and other types of commuting, active commuting to work, right? These all have been researched and viable options when they're available. The practicality of them, jury's still out in terms of, again, another situation that we're looking at a lot of opportunities to express ways that we can improve physical activity, opportunities for physical activity, but are they realistic, right? But work perhaps is more realistic than some leisure time activities, because when people are left to their own devices in leisure time, particularly when they have less access, they have less social support, they have some barriers with socioeconomics and perhaps living scenarios in an area of high crime and safety is a concern, lack of access to organizations and programs that will help them facilitate that. And also we have to remember, childcare that's free and that has some type of service. So this is critical in terms of understanding that. So leisure time, while important and while there's evidence to support it, may not be the most practical. Usually some type of social dynamic. We've seen that very largely with things like Peloton and also CrossFit. Regardless if you love or hate those modalities, they have provided a massive community of people to get out there and be more active in their own way, whatever interests them. There is some research out there by Jenkins et al. That determined that virtual and non-face-to-face activity is something that is very beneficial when it comes to cardiovascular health and improving some of those health-based outcomes. The biggest thing as well is giving people some more marketing scenarios, right? Some things that they're seeing displays, whether it's inside a building to emphasize using the stairs over the elevator, or just anything to get people's attention to do things a little bit more actively, right? Obviously, providing active environments is critical, although very expensive. Additionally, wearable technology, right? Some research by Blunt et al. Has really shown that wearable technology has improved outcomes for increasing physical activity within the population. But again, that comes back to socioeconomic status and are they available? Are they accurate? Things of that nature. But in my mind, the lowest hanging fruit here is going to be, can we use some type of population screening? We do that already. How can we better implement that to triage people who are at great risk? We do that with family histories as well. But honestly, the biggest touch point in addition to work is going to be the healthcare and medical field, right? Most people, 60 to 65%, maybe more, see their primary care physician every year. So that is a huge touch point. And I know we do this already. There has been some, you see an exercise prescription referral program here with the forms associated, right? This has actually been substantiated in the literature as something that has been highly effective, at least 12 months post recommendation, right? There's been some other components that have been a little bit less effective in the medical and healthcare space, i.e. just providing medical advice or just providing some advice with maybe some tracking and follow-up, a little less effective, usually effective somewhere between 6 and 12 months. I don't think we have a lot of research looking at long-term effectiveness of how do we best influence physical activity increasing. But I think the medical and healthcare space, I think, has to sort of lead as the touch point, and then providing surrounding aspects and strategies, whether it is at the workplace and providing more opportunities in that way, whether it's transport to the workplace. I don't think that's necessarily a viable option. It may be in DC, but certainly not across the whole population. So there are some things that we can certainly work on in those populations. And then when we talk about children and adolescents, school, we have to reintroduce school-based physical activity. It is absolutely critical. It's the biggest touch point. We know this from a nutrition perspective. We need to integrate that. There really isn't any better option, according to the literature out there, in terms of mandating physical activity within the school environment. And I understand why it's been removed, but I think it's the easiest touch point, and the most time that kids spend is going to be in their scholastic environments. What better way to incorporate in some way, shape, or form, from a fun standpoint, physical activity? Obviously, there's a ton of barriers there, but I think they are the lowest barriers, the lowest hurdles that are available as compared to more leisure time access, which is way too highly variable to say that that's going to be our primary touch point or primary goal with the lowest hanging fruit. So again, in the children, 60 minutes a day, lowest hanging fruit, got to be in the schools, got to be in some type of education, whether we gamify it with technology or offer physical activity outside of school or within school, and vary the opportunities. I think that that's critical. Now, whether what we're seeing with our current freshman and sophomore students is as a result of them not having those opportunities in high school in conjunction with COVID, don't know. But I think it certainly is a factor that's important. So ultimately, in the end here, I just want to conclude by saying that I think we need to move back to the basics. And we really just got to get people moving, and they need to understand what movement means and reduce the amount of outsourcing that we're doing. Then we can start addressing sort of the activity and getting enough activity. But if we just stop outsourcing one or two things in our daily lives, whether it's cleaning our house, mowing the lawn, doing some additional cooking, baking, whatever it is, so what's the lowest hanging fruit? What's one thing that you can take back yourself to increase your caloric expenditure, increase your ability to challenge the cardiovascular system so that it can adapt and find solutions as it's intended to do? So to reinvigorate that. And then that, I believe, is going to be our biggest bang for our buck, while we still try to reintegrate more activity within our daily lives. So in the end, the bottom line is we got to move more often. We got to move in different patterns. We got to find different areas that we can do that. If we can do it outside, if we can do it with a proper nutrition and diet program, which is a whole nother conversation, that would be absolutely optimal. But in a nutshell, move more, move in different patterns, move more often. And if we can do that, I think we can do much better than 5% in the next decade with the general population. But again, as it ties to this whole conversation, we all need to work together, and we need to find solutions. Thanks again for having me, and I'll take any questions if we have time.
Thank you so much, Kyle. That's wonderful. I will have you know that I stood and sat 3 or 4 times during your talk, and I used my under-desk elliptical, so I'm hopefully following your instructions. But I really liked your idea of un-outsourcing, because I think that's a different way of thinking about this than people typically think about it. Like, I think okay, we're at work, I need to have a standing desk, that has become kind of normal, but the un-outsourcing is a different way of thinking about this.
Well, I think that is one thing that I didn't mention as well, and I'm glad you brought that up, is one of the things that we did really well here in the School of Public Health is design the building in such a way to increase activity. And just anecdotally, from working here for the better part of 6 years, we don't use it. We don't nearly take advantage. Most of my students don't know that every faculty and staff member has a standing desk in their office because nobody uses them. It's very rare. And so again, thinking about why, right? We put all these things into place. We put these interventions that supposedly are going to work, but why aren't they being used? And again, it comes back to, at least in my opinion, a little bit has to do with behavior change. A lot of it has to do with behavior change. So yeah, I appreciate that you were doing that during the talk, but I think trying to get the broader population to understand. Again, this isn't the school of public health.
Right.
So
If we can't get it to work there, that's
right. What can we do if we supply the things, where's the knowledge gap? Where's the implementation gap? But anyway.
Yeah, I think that's the perfect point to end on, actually, because I think that is where a lot of things get hung up in the world of health and medicine is we often know what to do. That isn't often the problem. It's actually making it happen and making it just a habit. So it's not even something you have to think about, ideally.
Agree.
All right. So with that, thank you so much for joining us. It was a really great talk, and it will be available online for those of you who want to share this.
Thanks so much. I appreciate it.
Hi, everyone.